My name is Omar Torres. I am the Dean of International Business and International Office at Universidad de Xalapa. On behalf of Universidad de Xalapa and the University of Nebraska Medical Center College of Public Health, it is an honor to welcome you all in this unique forum, Public Health Understanding and Action, Addressing the COVID-19 Pandemic. I would like to thank Dr. Alejandro Escobar Mesa, member of our Med School Board of Consultants, who kindly accepted to moderate this webinar. I am pleased to share with the audience his professional bio sketch. Dr. Alejandro Escobar is a medical surgeon graduated from Universidad Veracruzana. He's a specialist in epidemiology from the National School of Public Health, certified as a public health specialist by the National Council, full member of the Mexican Society of Public Health. He was awarded with the 2015 Sanitary Merit Medal for the Society of Public Health in Veracruz. He has participated in various courses, conferences, and diploma courses in Mexico, the United States, Canada, Argentina, Norway, France, and Japan. He was a professor and temporary researcher at the Institute of Public Health from 1982 to 1987. Since 1985, he has been a professor at the Faculty of Medicine at Universidad Veracruzana. And since 2016, he's a professor of epidemiology and public health at the School of Medicine at Universidad Anahuac, Alba. He has published several articles in index magazines and journals. He's a scholarship holder of the International Cooperation Agency of Japan in reproductive health programs in Tokyo and Okinawa. And he's also a scholarship holder of the French Embassy, Bordeaux and Grenoble, in health programs for the elderly. For almost 40 years, he worked in the public health area at the government of the state of Veracruz Health Office, specifically in the prevention and control of infectious diseases. Welcome, Dr. Escobar. It is an honor. Bienvenido.
Thank you very much, Omar. Good afternoon, everyone. My most sincere gratitude to both the University of Nebraska Medical Center at Omaha, Nebraska, and Universidad Anahuac Xalapa Med School. I am honored to participate in this forum, and I would like to express my gratitude too with our special guest today from the public sector, our members of the Med School Board of Consultants, faculty members. COVID-19 pandemic marks the presence of an old enemy. Some days ago, I was reading a statement at one BBC publication where they highlighted that throughout history, nothing has killed more human beings than the viruses, bacteria, and parasites that cause disease. Not even natural disasters like earthquakes or volcanoes, not war, not even close. In the last months, our society was practically shut down as the number of infected people continue to grow all around the world, with evident consequences in the economy and in various strategic areas of our societies. Along with these changes, an unprecedented optimization of high technologies has increased global communication and interinstitutional cooperation. An honorable example of successful collaboration is the one UNMC College of Public Health and UX School of Medicine have consolidated by means of the international global engagement offices initiatives at both fronts. And now Omar Torres will introduce our panelists. Omar, please.
Thank you, Dr. Escobar again. Ali S. Khan is Dean of the College of Public Health at the University of Nebraska Medical Center, UNMC, and a former Assistant Surgeon General with the U.S. Public Health Service. Dr. Khan's professional career has focused on health security, global health, and emerging infectious diseases. He completed a 23-year career as a Senior Director at the Centers for Disease Control and Prevention, CDC, which he joined as a disease detective, and where he led and responded to numerous high-profile domestic and international public health emergencies. Dr. Khan was one of the main architects of CDC's national health security programs and continues this work at UNMC, which has been nationally designated to prepare the American healthcare system to respond to outbreaks of high-hazard pathogens. He also continues to actively support global outbreak responses, such as the West Africa Ebola outbreak in Sierra Leone and the Rohingya refugee crisis in Bangladesh as a member of the World Health Organization Global Outbreak and Response Network. As Dean of the UNMC College of Public Health, His focus is in improving health systems and community-based health transformations. His vision for the college to play an integral role of creating the next generation of guardians of public health and devising innovative solutions and new interventions to address public health challenges. The college is committed to education that is measured by the impact of our communities. This impact starts with making Nebraska the healthiest and most equitable state in the union and creating a national and global model for wellness. Dr. Khan received his medical degree from the State University of New York Downstate Medical Center in Brooklyn and has a master's of public health from Emory University School of Public Health. He completed his pediatrics and internal medicine training at the University of Michigan. He has authored numerous papers and publications. He has consulted extensively for multiple US organizations, corporations, ministries of health, and the World Health Organization, where he serves on the steering committee for Global Outbreak Alert and Response Network. Dr. Khan is the author of the book, The Next Pandemic, on the Front Lines Against Humankind's Gravest Dangers. It is an honor, Dr. Khan. Welcome to this forum. On the other hand, I am also honored to introduce UNMC Dr. Armando de Alba Rosales. He was born in Tuxpan, Veracruz, Mexico. He's a faculty member in the Department of Health Promotion at the University of Nebraska Medical Center, UNMC, College of Public Health. He earned his medical degree from the Autonomous University of the State of Puebla and is currently an active primary care physician in the state of Veracruz. In 2013, Dr. de Alba received his master's degree from public health at UNMC. Currently, he's a PhD candidate in clinical translational research. From 2013 to 2014, Dr. de Alba was a National Health Disparities Fellow of the U.S. Food and Drug Administration, Office of Minority Health. From 2010 and 2013, Dr. de Alba worked in the Mexican consulate, assessing and addressing the healthcare needs of the Mexican immigrant community. As coordinator for the states of Nebraska and Iowa, he collaborated with the different organizations in the design and conduction of healthcare interventions that successfully impacted and benefited the underserved communities of both states. Further, Dr. de Alba has assisted in various projects as the lead coordinator, including providing the communication resources for UNMC to the Latino community during the public health emergencies in Ebola in 2014, and the most recent with COVID-19. In 2016, Dr. de Alba initiated a partnership between UNMC and Universidad Anahuac, Xalapa, first conducting binational academic and research projects between UNMC, COPH, and the Medical School of Universidad Anahuac, Xalapa. 4 years later, the partnership with Anahuac, Xalapa has expanded to multiple colleges within the University of Nebraska. In 2018, Dr. de Alba was one of the 31 professional Mexicans around the world awarded from the government of Mexico with a Medal of Honor as a Mexicano Distinguido en el Exterior. In 2019, he was the recipient of the UNMC COPH Excellent in Teaching Award. This year, Dr. de Alba has been selected as a recipient of the President's Excellence Award for the University of Nebraska. According to the university website, the President's Excellent Awards are the most prestigious awards for teaching, research, and community engagement. Dr. de Alba is the first Mexican receiving this medallion. We are honored with your participation, my friend, in this forum. Dr. Escobar, we are ready to start. The microphone is all yours. Thank you very much.
Thank you very much again, Omar. We are all impressed with our panelists' professional trajectory. I would like to start this discussion with some question to Dean Khan. Dr. Khan, thank you for being on the front line of this pandemic and being with us today. Thank you very much. The first question is, as a former CDC top official and a disease detective who has led and responded to numerous high-profile domestic and international public health emergencies, in your opinion, why did the COVID-19 pandemic evolve into an emergency all over the world? And how is it different from other coronavirus outbreaks like SARS 2002 and the MERS in 2012? Please, Dr. Khan.
Thank you very much, Dr. Escobar, for that question and the invitation. Thank you, Dr. Omar, for that lovely and way too long and generous introduction. And of course, Dr. Alba for inviting me to join this panel. So while this is a global pandemic, it's really over almost 200 different epidemics in every country. So there's a different answer in every country for why they were successful or not successful with their outbreak. But in general, this disease spread so widely over the world because even in high-income countries, we were not prepared as we needed to be for a global pandemic. So we didn't have the disease detection systems in place. We didn't have the laboratory systems in place. We didn't have the number of epidemiologists and contact tracers within our local and state health departments and national health departments to get the work done. We didn't have healthcare systems that were ready to surge when all of a sudden you had hundreds of cases showing up at the front door saying, I need a bed or I need a ventilator. And you need to protect all your healthcare workers with PPE. So we clearly, despite 2 decades of preparedness since the last SARS pandemic, we have not gotten preparedness right. Now, in some countries, that's also coupled with, to be very frank with you, a failed response on the part of multiple people. So this is one of the unfortunately tragic things about this outbreak is you can point to failures at the national, state, and local level. You can talk about failures in the healthcare system, failures in the public health system, failures in our elected officials. There's lots of blame to go around for where we find ourselves from a response standpoint. And so some countries, New Zealand, Vietnam, Thailand, Taiwan, have treated this disease just like SARS, and they've contained the disease and eliminated the disease, and it's gone. Other countries like China with 1.3 billion people are on their way to elimination. Okay, so these are countries that have had an excellent response, even though they, for example, China clearly stumbled early, as you would expect, since that's where the disease was found, but they have figured it out. All of Europe has gotten their cases under control. And then there's countries like the United States that has still been unable to get their outbreak under control. We have as many cases today as we did back in April. I think we may actually have more cases now. So we clearly have been unable to get our outbreak under control. So the second question you had was, again, going back to SARS. So the disease COVID-19 is caused by coronavirus. There's 4 coronaviruses that we know all the time that cause the common cold, but there's 3 that cause these severe illnesses that tend to come from animals. And this SARS coronavirus 2 is very similar to the SARS coronavirus 1 we had previously. Unfortunately and tragically, this new SARS coronavirus, you are actually infectious before you're sick. And potentially 40 to 50% of cases occur before you are sick. And so there's a lot of transmission within families and the community while somebody is sick or mildly sick. And then there are obviously some asymptomatic or mildly symptomatic people causing infections. So that is what has bedeviled us about responding to this outbreak. The original SARS, when we saw it, in that disease, you were more infectious as you got sicker. So most of those cases tend to occur in healthcare settings. So those were really healthcare outbreaks, and that's how we managed the original SARS outbreak so efficiently compared to this one. But unfortunately, given our failures in preparedness, failures in response, and conceptual failures, many people thought this was influenza. It's not influenza, it's SARS, it's Ebola, and they never adopted this containment strategy. So I think that's how we find ourselves where we are today in the world.
Dr. Escobar, probably your audio is off.
I'm sorry. Excellent points, Deacon. How do you think the US is doing at this front? What are some lessons learned?
There are a lot of lessons to be learned from the United States. right? So one is the strategic mistake, what I call a lack of imagination within the United States, to treat this like influenza instead of like SARS or Ebola. And because of that, we never had enough testing in the United States up front to understand where disease was within our communities and then quickly extinguish it or clamp down on that. Then as we have continued, unfortunately, we have politicized this virus. And I tell people as a physician, I see either live people or dead people. And when you're dead, it doesn't really matter what your political affiliation or other associations may be. But here in the United States, unfortunately, we have politicized this virus. We see this now in efforts to tell people to wear masks. So that was an early failure of how we treated this disease. We also made some big scientific mistakes. Besides the testing, for example, in the United States, we originally told people do not wear masks. That was a mistake. We should have told people to wear masks. And unfortunately, some of those lingering mistakes remain in the outbreak. Now, we had our peak, and then we had 4 to 6 weeks of essentially stalled response in the US of 22,000 cases a day. And this disease should better be thought of as a forest fire or a house on fire, which is if you don't continue to get it down to zero, it will just light another spark somewhere else. And that's essentially what we saw. So in the United States, because we failed to get those cases down, the disease has now gone elsewhere, and now we're seeing problems in Florida and Arizona and Texas as we've started to open up the US. So I think these are all lessons for Mexico as they think about how do they respond to their disease, that they can look a little bit north and say, okay, these are things we can do better. Starting with recognizing we all have a responsibility. The government's responsibility is to test and trace. That is their responsibility. Find each case, isolate it, and then find their contacts and put them in quarantine. And then there's our responsibility, which is wear a mask, wash your hands, and social distance. And if you put those two together, you can be New Zealand.
Dr. Escobar?
You're on mute again, sir.
I'm sorry. From our global perspective, Dr. Kang, how is Canada, the US, and Mexico doing in the region compared with other regions in the world?
So Canada is doing excellent. They've gotten their cases down below 40 cases as a running average of 40 cases per million population per day. So Canada has figured it out. They also had about 2 to 3 weeks of stall. I review their numbers often, but Canada is spot on. They have continued to get their cases down. So they're in a good place, and hopefully will continue to move along the lines of Europe, completely open again, schools, restaurants, stadiums, etc. So they seem to be on the right path. The United States, as I said, has more cases today than it ever had, so we're clearly on the wrong path. And the same thing's true for Mexico. You have an inordinate number of cases in your country. Today you hit 40 cases per million per day as your running average. Your case fatality is 12%. I think that probably puts you in the top 5 or 6 countries in the world for your case fatality. Your hospitals are overrun. 80% of people with COVID can't get a ventilator in Mexico City, according to the recent data I saw. Your positive number of people tested positive is greater than 50%. So yes, I must say there's a lot of work to be done on the part of your elected officials in public health and your community to get your outbreak under control, because clearly it continues to be going up.
This brings me to the next question. If you could mention 2 countries that are doing well combating this pandemic, which would they be and why? What have they done well? And what are they currently doing?
Okay, so I'm going to be careful because I could just point you to New Zealand, but let me frame this a different way. Let's point you to Japan. They were having they thought they had their outbreak under control, and then all of a sudden they started to see an increased number of cases. And what they did is they very quickly ramped up to increase test and trace, right? They're just good old fashioned boots on the ground, public health, everybody wearing a mask, and Japan checked their outbreak and got it back under control. Okay, so that's a good example because there were a lot of cases that they were continuing to stamp out. And this lesson, this is the exact same lesson every place else that's done a good job, is that they have relied on public health and good data, right, to drive their outbreak down. And so this, again, as I said, you know, Taiwan, Hong Kong, et cetera, Thailand, all at 0. And trust me, China, people talk about a spike in China. They're not having a spike. They had 100 cases, but they're committed to 0. So they essentially shut down their major capital to get to 0. So that shows you how committed they are to 0.
These are important factors to take into consideration. Great points, Dr. Khan. Okay, in Mexico, there is a controversy about the role of testing for SARS-CoV-2. Mexico is among the countries, as you know, with the lowest rates of testing in the world. Why are screening tests important? And do you think that everyone should be tested?
So actually, I believe your official policy was to test 1 in 4 when this outbreak started. Is that correct? Yes, it is correct. Yeah. So we will be glad to send you a University of Nebraska Medical Center College of Public Health trained epidemiologists to help with some of these issues. We have lots of them, and we'd love to train yours also if we can. So testing is invaluable because that is the data that tells you what's going on in your country. And if you don't test people, how do you isolate them so they don't infect somebody else? It's impossible to isolate people and keep them from infecting others if you don't know they have the disease. And then, so that's from the public health standpoint, right? You need to understand where the disease is so you can mobilize resources. You need to find your cases. And then from the clinical standpoint, if you don't test people, how do you not mix those who are infected with COVID from those who aren't infected with COVID? So basically send them to hospitals to get infected. And then finally, from a treatment standpoint, we now know that you can use dexamethasone to save lives. Now, the data on dexamethasone and ARD, acute respiratory distress syndrome, is actually kind of equivocal, to be honest with you, for those who spend a lot of time looking at the data. However, with COVID-19, it's very clear that if you're on a ventilator and you have COVID-19, give them dexamethasone. So yet another reason why you need to be testing people in Mexico. And not everybody. I would never espouse in the United States you test 333 million people a day. Right? Everybody. But you need to make sure you get your case positivity down below 5%. And then you'll have a good sense of what's going on. And more importantly, you'll have a good sense of getting cases down, because I know I only have another minute or two, so I'll stop there. But we're talking about the health issues. Please do not forget that getting this disease under control is an economic imperative. Right? Our border is closed because of this disease, right? And it's closed with Canada. And I'm not sure if Canada's ever going to open it up to us until we get our disease down. So this is an economic imperative. And if we don't get disease controlled amongst us, trust me, people will choose to travel to countries like China and Japan and New Zealand, etc., for business and work and pleasure, as opposed to coming to some place where disease is out of control. So it's an economic imperative that we get this disease under control. And I'll stop there. Apologies for taking too much time.
Don't worry. Thank you very much, Dean Khan, for the effort that you and your team are doing in protecting the Healh our communities. It's a great pleasure to have you here today with us. Now, I want to turn to Dr. Armando de Alba. Dr. de Alba, we also thank for being on the front line of this pandemic. During this pandemic, we have seen you very actively with the Latino and Mexican communities in the US and Mexico. We know that in the US, the Latino population is among the groups with higher rates of COVID-19. Can you explain to us why this is? And are there similitudes with what we see in Mexico?
Well, thank you very much for that question, Dr. Escobar. Before I continue, I want to express my gratitude to Chancellor Linares to the authorities, also Maestro Eli Marin, the provost from the University of Anahuac, Xalapa, the deans, Omar Torres, Dr. Cano, Dean Gerardo Hernandez, and to my authorities from UNMC who are allowing me to be here with you all, and the presence of everyone here in the audience. I also want to acknowledge the presence of the Consul of Mexico, Guadalupe Sanchez Salazar, and the Consul of Mexico, Jorge Ernesto Espejel, who I know will be joining us to this conversation. So the question about why do we see the Latino population having higher rates in the United States and some similarities there? Well, we have to address COVID-19 from different dimensions. So we need to look at the biological factors, which are the ones that we look in the clinic, in the hospital, but also, as we say in the public health arena, we need to look at the social determinants of health. So that means the individual behavior, the family factors, the places where we live, the places where we work, and socioeconomic factors that are equally important than those biological factors. For example, when we talk about biological factors, what do we know now at this point? Biological factors associated with COVID-19 are hypertension, diabetes, cancer, obesity, smoking status, and just to mention just a few of them. But the three first ones that I just mentioned are the three leading causes of death in Mexico. And in the United States are part of the 5 leading causes of death among Latino populations when we compare them with other groups in the country. So those are similarities. So we're in a very vulnerable situation. Plus, when we start to also look at some individual behaviors, so we look at those factors that also are embedded within our culture. For instance, we are huggers and kissers, right? So we like to hug and kiss. So what are some recommendations? What are the things that we know now? How do we transmit the virus? Via droplets, via saliva. So we kiss someone, we're putting the virus very close to that person, close to one of the main of entrance, right? The other thing is hugging. We're not respecting that famous physical distance, social distance. So that put us again in a vulnerable situation. So other factors, for example, in the United States, the Latino population work in meatpacking plants, in the agricultural sector. And those are jobs that unfortunately don't have enough protection or protocols to, in this case, protect the health of the workers. And so this is very similar when we compare it with what's going on in Mexico. For example, people have to go to the market, so a los mercados. So people have to move in public services such as the metro, the subways, the bus, and it's very packed. We don't have protocols in place to protect the health of our communities. So, but there is an important factor that I want to mention that happens in the United States, and we must recognize that this is a main factor, a main contributor for these numbers, which are the disparities in healthcare. So minority populations, not only Latinos or Mexicans, but other groups like African Americans, they suffer of disparities in healthcare. And they don't have access to healthcare compared to other groups such as white. This definitely impacts negatively the health of the community. Let's go back to specifically the Mexican community within the United States. So a lot of our communities don't speak English. So the communication sometimes is delayed, or there is not in existence to communicate with those who speak in Spanish. And when you find that information in Spanish, sometimes it's not culturally appropriate. So not because it is in Spanish means that it's appropriate for that community to understand what's going on. And that is something that I experienced and I observed during this pandemic. So these are just some examples. And another key factor there is, let's call it as is, discrimination, racism. There is individual racism that happens here too. And there is structural racism in institutions that do not provide, or the secondary impact of this, it's a low quality in healthcare.
This is very important information, Doctor. We cannot forget our Mexican communities outside of our national territory in a pandemic like this one. We must also care for their health. Okay, the next question, under your role as a healthcare consultant to the Mexican government in the US, what are some practices and challenges that you have observed while assisting during this pandemic?
Absolutely. Well, I would like to start with the good practices first. So something that I have seen, it's the union that exists with the healthcare sector. Like for instance, let me share an example. I belong to one group, an association in the United States called the National Hispanic Medical Association, which is the largest association of medical Hispanics in the United States in front of the government. So in the moment that we started to see cases and we started to have alarming response, or we started to respond to this emergency, we created communication groups. And we're a big number, like we are around 100 physicians in New York, in Washington State, East Coast, West Coast, North, South, and we were all exchanging practices. We were all exchanging concerns, but also support. That was beautiful. That's been very beautiful and continues up to this day. And we're also connected with other groups from other, associations, American Medical Association, and it's a beautiful network. And there is trust, and we are able to see what are the latest updates, not only within the United States, but also around the world. We do accept what's going on in other countries. Like we get information from UK, we get information from Germany, from China, from all over the place, and we discuss and we identify what are the best practices. Something that is unfortunately a contrast that I see with Mexico, but anyway, so we will talk probably in another question about this. But in terms of also good practices, I would like to also recognize the work of the consulates of Mexico within the United States. For those who are not familiar, there are 50, and maybe I'm wrong, but the last time I confirmed this, there were 50 consulates in the of Mexico in the United States. This is like a network connected with the Embassy of Mexico, where they have offices, and one of those offices are the Ventanillas de Salud, which is like a little health department, and they collaborate and partner with a local healthcare agency. So I witnessed firsthand how the Ventanillas de Salud and the consulates collaborated and went on board with the local agencies, the local health department. In this case, here in Omaha, we were in communication with the head of the health department to start efforts about health promotion and disease prevention. I was actually invited to be a speaker in a webinar with all the consulates or directors of the department of all the consulates that the embassy coordinated to educate, to inform, and to brainstorm together early in March when everything started to kind of like gain a force over here, or power. So there was a good willingness and proactiveness from these offices. So I wanted to acknowledge the important role and the effort from the Ventanillas de Salud and the people who coordinate those, who are community health workers, community healthcare coordinators, who are putting the effort, their spirit to protect the health of our communities. So that is, I will say, I will stop there in terms of the good practices. In terms of challenges, something that I saw or that I have seen is the lack of information. So there is not, early in the process, I was able to identify that there was not information in Spanish, and when that started to happen, the information was too technical. So those are the things that actually was able to contribute with the healthcare services. I had the honor to participate in some TV interviews or radio stations to actually inform and empower the community. But here is the challenge. The problem that happens within our community is that they receive mixed messages. Let me be a little bit more clear about this. So in the United States, for instance, the Mexican community, they keep the communication with their families in Mexico. So in the United States, we started to have a response, a very strong response to the emergency between February and March. We were providing recommendations about the staying home, about hand hygiene, a social distance. While in Mexico, there were some contradictions about if this was a serious disease, if they had to stay at home or continue. And I'm talking around February or March, when I am following closely what's going on in Mexico, and I know there was a lot of controversy going on at that time. So our community here, and this is a point that I haven't heard in terms of discussion, but it's important that we presented. Our communities, our Mexican communities here, were listening what was going on in Mexico. That's why they were confused and disconnected and not following the recommendations that here in the United States we're trying to do. So I think it's important that we also see it from that international perspective to work in collaboration. And Mexico should definitely identify what is happening outside of the boundaries to see how we can actually help the Mexicans that also live beyond the borders of our nation. And I think you're muted.
Your audio, Dr. Escobar. Please turn on your microphone, Dr. Escobar. Yeah.
Sorry, I'm sorry again. I have to ask you, Armando, as a Mexican healthcare professional, how do you think Mexico is doing against the COVID-19 pandemic?
Okay, well, I have to say upfront, probably a personal disclaimer. I do not have any affiliation with any political party. I do not belong to any, I don't have a personal preference. So I will speak here as a Mexican, as a professional that has gained skills, medical skills, that has obtained medical skills, public health skills, and research skills. With this being said, I also want to start by recognizing the tremendous effort of talented colleagues, physicians, doctors, nurses, healthcare professionals, people who work in the clinics, people who work in the hospital, risking their lives every day, people who have passed away, who have unfortunately died because of this pandemic. I want to recognize their tremendous work. With this being said, and I want to be very clear about my response, I think Mexico can definitely do better. As we have heard from Dr. Khan, I think we have to be clear that emergency responses needs to be led by science. They cannot be led by political projects. And so we need to actually collaborate in community with the global scientific community to learn best practices, to learn what's happening in other countries, to actually implement those practices in our country, in Mexico, and also document our practices with scientific rigor to see how our community responds. So create our own data with scientific rigor. So we definitely need to also reassess, do a self-evaluation of what is not working and reconsider to change the practice or change the direction. Other countries have done it. United States have done it. They have had the courage to identify and even express it freely, what they have done wrong and how they are changing the direction. I would love to see Mexico doing that, and especially to our authorities. It's okay to do it. The other thing, it's I observed division, contradiction between the sector, the scientific community within Mexico. There are people who are passionate, who wants to protect the health of our communities. And unfortunately, I see division between, or disaccreditation and disregarding these voices when this is a time to be unified. This is not a time for division. Regardless of your political interest, regardless of your nationality, we in the world are on the same boat. We have the best interest to overcome this challenge. This is not just local. We need to be unified. And again, we really need to be doing and thinking, what are we gonna be next? And taking considerations and like the ones that we just heard about testing, we need to reconsider how we're using the test and the importance of the test. We need to identify those practices because they are based on evidence. And I will probably stop there and we'll probably just go to the next question.
Great observation, Dr. Alba. Doing assessment of what we do in public health is always important to identify what works and what needs to be improved. Okay, today in the audience we have several students who are initiating their careers in healthcare. Can you share with also some of your contribution as a Mexican healthcare professional within the U.S. healthcare system, especially during this increased time of need?
Thank you, of course, and I take the time to say hi to probably some of the students. I extended the invitation to my students from the summer club course, Foundations in Public Health. Probably they are listening this, and thank you for joining as well, some of the students from Mexico. I will probably address this question with a couple of recommendations and some messages that I like to share with my mentees or some students. First, never forget your roots, never forget where you come from, because that is something that I have applied, and that was something what brought me to the United States when I was first able and honored to serve in this case, Mexican community and immigrants communities, people who were coming from our country for a better life. So I was able to identify their needs and also their frustration because they couldn't get to the healthcare services that they need, not because they didn't want to because they didn't want to respect the system, but it's because they are coming from another system. I was able to understand that because I was trained in Mexico, and then on the other hand, I'm able to see also some of the challenges that the healthcare system, the U.S. healthcare system has with our communities. So the way how I see myself or the work that I do is being a bridge. I like to be a bridge between the community, in this case, the Latino or Mexican community, and the healthcare services. And the other message here probably will say, the more you learn, the better you can serve. I have been fortunate to first obtain a medical degree, then a master's in public health in one of the best programs, if not the best programs in the world. Yes, UNMC, there is a sponsor there. Not because my dean is here, but I really mean it. And the other, and of course my chair who is here, right? You might say that I'm biased. But in addition to that, now I'm doing also a PhD, my second degree in research. But what I'm trying to explain with this point is that, you can gain skills, and those skills can allow you to contribute with challenges or gaps that exist in the healthcare services, in the medical field, the research field, in the public health field. We have just talked about some examples, but let me close this probably answer with one analogy. Like, for instance, I like to see it as a bakery store, like a cake store. So in a cake store, you need to build the skills and have the skills to sell your cakes one-on-one, right? And that will probably be like the clinical care one-on-one approach. But then you also need to be in a community. You need to serve the community. You need to identify what are the preferences of that community and be also the bakery of that community. So that will probably be the public health skills that I have gained. But the other skills, but there is also a master chef that creates the formula, that creates the formula, but also creates the cakes. So that master chef, it's actually in the analogy and in the real world, coming from the analogy to the real world, the PhD. So those people who know how to create science, how to develop protocols and guidelines. So at this point, I feel that I have a bakery, my cake shop in the United States, and not only being a business person, but also knowing how to provide the cakes, the appropriate cakes at the individual level, at the community level, but also how to be a chef that can create the cakes. But let's remember, the cakes are not for your fridge. The cakes are for the community.
Thank you so much, Dr. De Alba. Your commitment to the community and passion for these studies drives impactful change to communities across the borders. Thank you for representing Mexico very well in the United States. We are now going to move into the panel discussion portion of our webinar. During this discussion, I encourage our viewers to leave their questions in the chat box below. We have been gathering questions in preparation for this meeting, so we wait to some of those while we monitor the chat box. Okay, the question number one is, we have all heard the discussion about whether to wear a face mask or not in public. Face masks are cubrebocas in español. Does the use of a mask in public really work? What is your best recommendation for the general public? Please help us understand why this is important. Dr. Khan or Dr. De Alba, please.
Dr. Khan, your microphone is off.
Thank you very much, Dr. Escobar. So let's start with the biology of the disease. Right? We get infected by something called respiratory droplets. So this is when I cough, when I sneeze, when I talk, that is what infects people. We have lots of epidemiologic data that suggests that over 80% of disease, 80 to 90% is transmitted that way. So this is close contact with somebody within about 6 feet for about 15 minutes. So when you think about that, then it's pretty clear that if you want to protect yourself from respiratory droplets, you should be using masks. And masks serve two purposes. One purpose is if I'm infected and don't know it, then I am not blowing out these particles to you. And then the second purpose is if I come across somebody who's infected, the mask provides a barrier for those large droplets for me. So that is why we wear masks. And the data is absolutely unequivocal that if enough people are wearing masks, you will drop transmission in the community to a containment level. And this is no longer just modeling data. We have seen it in countries that have succeeded in containing their outbreaks. They have done so with a universal masking policy.
Thank you, Dr. Khan. One question for Dr. De Alba. What are the factors, indicators that tells you that a country is not ready yet for removing preventive measures such as staying at home or going to public places?
Definitely. Thank you very much for that question. But I would love to actually, if may I, Dinka, to probably put you on the spot since you are an expert and especially epidemiologist, and then I can complement it if needed. Please.
No worries, Dr. De Alba. I know you answer this question all the time, so you're just being kind to me. It's essentially what's going on here. That's fair enough. Okay, so there's a number of different indicators we use for reopening our economy. And I always start by telling people that to me, it's not an issue of open or not open. It's an issue of open safely or don't open safely. Okay, so that is the true dichotomy. And so we need to make sure that as we open, we have the systems in place to make sure that you don't open until cases are going down, obviously, but the cases will continue to go down because as people come together, you will see more cases. We already know this, right? So you need to make sure you have those public health systems in place, and you need to make sure you have the personal responsibility in place before you start to reopen. Now, as you reopen, what we have seen is that you'd like there to be less than 40 cases per million per day on a 7-day running average. That seems to be about the right place to say, okay, it looks like you've got your outbreak under control. Yes, you need to see it's going down. Yes, you need to make sure there's sufficient healthcare capacity if it goes back up again. So, you got to put all that in place in addition to, as I said, the contact trace and test and trace. But that seems to be about the right place where you can start opening up again. Do recognize that you need to always be careful of people with chronic conditions. Dr. De Alba outlined who those were in Mexico. So, I have a 93-year-old mother, and I still tell her I'm going, godmother, and I still tell her I'm doing your shopping for you, right? Until cases really come down in the community. So those are some of the triggers I use. And I'm very cognizant as a public health professional that there's also political and economic reasons to open. So my focus is always on, okay, if that may be a political or economic reason to open, make sure public health is ready and doing its job, right? Make sure people are masking. And then please, if you're gonna open, open safely.
Then, Dr. Khan, when and under what circumstances is appropriate to consider to reopen schools?
Do you want to take that one, Dr. Alba? Do you want me to? You are being too kind today.
What do you want?
I'm happy to translate in Spanish too, but anyways, go ahead, please.
Say it in Spanish. I'm sure a lot of your audience is in Spanish. Maybe you could answer the questions in Spanish instead of English, although obviously they all understand English as well as anybody else. But
Absolutely.
your familiarity with your own language makes it easier. Schools. I'm absolutely the wrong person to ask about schools because I have a contrary view of many other epidemiologists. I think the data says that in COVID-19, children are not the main vectors of disease within the community. So this whole idea about schools comes from influenza data, where without a doubt, influenza is driven in a community by schools. We know that, right? The kids bring the disease home, and so the kids are the ones that you need to really worry about in influenza. But we have seen with this disease that that's not true. It's the parents who bring the disease into the home. It's not the kids who bring the disease into the home. And now, if you look at there's about 3 or 4 studies that have come out looking at Europe and looking at what set of measures made the most difference. And in most of those studies, the moment you start controlling for all of the other control measures, schools come out of the mix. So I am not convinced that schools are a big driver for infection within our communities. So my suggestion, and what the University of Nebraska Medical Center is doing, is they will be reopening schools in the fall, right? That is what we're going to do at a university setting. And I think at a university setting is more risky than what you would do if you started opening up K to 5 or 5 to 12 or whatever. So as far as I'm concerned, get your disease under control and open schools. But what I put pressure on parents. I say, if you want your little boy or little girl to stay healthy when they go to school, then go talk to your governor and mayor and public health people to say, get disease down in my community, because that's how I keep my children safe.
Thank you, Dr. Khan. We have another question. PCR testing versus antibody testing, what are the differences and why should they be used?
Okay, Dr. Alba, you got to take one.
Okay, I'm gonna take this one.
Okay.
All right, well, absolutely. Well, in general terms, we have 2 kinds of tests. We have the PCR and we have the serological tests. So PCR basically what does is diagnose active COVID-19 cases. So that is the main difference. And the serological basically measures antibodies for SARS-CoV-2. So basically people who already were in contact with the virus and eventually they develop the antibodies. That's what we basically see or identify with the serological test. So the way how I like to explain it in general terms, one is proactive, like the way when the disease is going on, and the other one is retrospective. It's kind of like, well, okay, well, you already were in contact, you already were infected, and then after even some weeks, you start to build antibodies. So that's kind of like the main difference. And probably I can pass it to you, Dr. Ken, if you would like to share something else.
I think you've got that, Dr. Alba. The only thing is I caution people with the antibody tests. So most of them are lateral flow tests. They're readily available. They should not be used to make acute diagnoses in people, as Dr. Alba said, even though they're commercially and easily available, because they're probably, they are no good in the early stages of the disease, without a doubt. Probably no good until you're about 10 to 14 days out, at which point that really doesn't provide any clinical information for you on what you would do for somebody. The other thing is, please, while these assays may suggest you're infected or not infected, they do not tell you if you're immune. So these assays should only be used at a population level to try to understand how many people were infected in a community or in a nursing home or some other setting. You should never, until we get better assays, individually say, I am positive as a healthcare worker, I don't need to wear protection anymore. So I would caution anybody, do not use the antibody assay for that personal reason.
There is another message that I would like to share, Dinkan, based on related to the testing that I think it's important to clarify with our audience, especially in Mexico. because when we talk about testing, it's not only about the amount of testing that we need to increase, but also we need to test early. So as Dr. Dean Khan already explained in his first questions, he was telling us that some people are infecting before they present symptoms, and some of them are people might present very mild symptoms. So the earlier we test, the better, the more accurate the tests are. So because in Mexico, I heard the other day a message that they are testing people who are very sick. That's how they are actually performing the testing. And there is actually a challenge, because we know based on data that the later you test, or when you test at the later stages, you might have some false positives compared when you test early. I think it's important. I guess the message that I wanted to share is not only it's about the quantity of testing, but also how early we start the testing.
Absolutely, Dr. D'Alba, because if you're testing people when they're ready to die, that provides you no epidemiologic assistance, right? They've already, days later, their contacts have probably already become sick and infected somebody else.
Exactly.
So you need to be testing immediately when people get sick. And if you have a good clinical suspicion, you test them again in 24 hours if that's negative, before you exclude them as being COVID-19. So yes, increased testing for a purpose, right? You know, it's not just, I don't want you to come tomorrow and say we have 100,000 tests or 200,000 tests. The testing is for a purpose, and that purpose is test and trace.
Thank you, Dr. Khan, Dr. D'Alba. We have here another question. We hear a lot these days around medication for COVID-19. Are there currently any medication that can be used to support treating the coronavirus? Or are there any medication that will prevent it?
I can probably start with that, with a simple, straightforward answer that up to this day, there is no an approved vaccine or drug that is for COVID-19. There are a lot of trials, there are a lot of vaccines in investigation, there are drugs that are being tested, and depending when you see this film, maybe it's gonna be changing in the next few weeks, because constantly this is an arena that is moving very, very fast. But in general, I think one of the main concepts is that we have therapies that are being tested based on the timing when the person is being infected, or when the person started to have like a deterioration in their health status. For instance, in the first 9-10 days, we actually call that as the viral mediated phase. And after 10 days, there is a second phase that we call it the immune mediated phase. So for the phase 1, the viral mediated phase, we have medicines or drugs that are being tested, such as chloroquine, remdesivir, etc., because we're using it for the first phase. And the second phase, actually, there is where we have the anti-inflammatory drugs, such as the IL-6 receptor blockers, etc., or steroids even. So I guess in general terms, we can look in this way. This is an approach, and this is why we have different drugs that act in different stages. And we have seen results in people who are more severe than people, and that's why one of the explanations what some drugs don't work in some people who have mild symptoms, etc. These are just general terms, but I will pass it to you, Dean, if you would like to polish the concept.
Thank you, Armando. Dr. Khan?
So thank you, Dr. D'Alba, and thank you for that explanation of the cytokine release syndrome that causes a lot of the illness at a lot of the deaths at the end for these people, and thinking about how we sort of titrate the drugs we use based on what the phase of illness is. So let me start by saying clinical management has markedly improved for these patients, number one, right? We have learned that they do not necessarily need to be ventilated early. We realize that maybe prone positioning can be very helpful for oxygenation. We realize that there may be other options address these people's hypoxia, and we're increasingly understanding the role of the complement system and coagulation in these individuals, and how can we modulate that to try to improve care. So that's the improved clinical management that we're seeing. From a drug therapy, currently, as Dr. De Alba said, and we're about the IDSA, the Infectious Disease Society of America recommendations are about to be redone. But my personal recommendation would be, based on the available data, that remdesivir can decrease 4 days of hospitalization. So instead of 15 days, you would have 11 days. There's a trend towards a mortality improvement, but that was not statistically proven. And based on that, we have an FDA approval to use that here in the United States. I do not know what the approvals look like in Mexico, obviously. And then we do know that if you have severe illness that requires oxygen, there's a wonderful study of 186 hospitals with the National Health System in England that just came out that shows that dexamethasone works. That is, and so it's a 36% decrease in case fatality if you're ventilated, and a 20% decrease in case fatality if you happen to be on oxygen, and no difference in case fatality if you weren't ventilated, if you're not on oxygen. So it's that nice sort of trend that suggests that the drug would work. That study is at a preprint server right now, has not been published, but my recommendation is that you identify your cases in Mexico who have a confirmed diagnosis of COVID, and if they're oxygenated, they should get 6 days of dexamethasone. Again, that's a personal opinion based on reading the literature.
Thank you very much, Dr. Khan. Let me see if we have more questions for the audience. Deyanira, have we more questions?
Yes, Doctor, we do. I guess we still have some time to answer some of them. This one says, in the future, we will have more pandemics. Will meat packing plants need to be completely redesigned so that they do not become infectious disease hotspots in the future? This is from Roger. I don't know if Dr. Khan or Dr. Armando could answer it.
Do you want me to take that one, Armando? Do you want? Thank you, Roger. That's a great question. Please recognize, Roger, that meatpacking plants, you could have just as well said to me any other congregate setting. You could have said long-term care facilities, for example, right? Or large businesses. So yes, unless we are successful in getting this disease under control, large factories, we need to figure out how do we improve practices within those entities to help protect people from getting sick. And meatpacking plants was obviously a good one because we have a large number of Hispanic population who work in these facilities here north of your border, and we want to protect them. There is work looking at a drug that we think may be helpful for prophylaxis. Unfortunately, you can only use it in men. So we're thinking about that as a trial. But, you know, I want to take your question in a different direction, which is back to the economic imperative, right? So if you're going to make cars, are you going to make them someplace where people are likely to get infected and the factory is going to get shut down? Or are you likely to go make them someplace where that's not going to happen? So I want to remind people, you know, there are countries that got rid of this disease without a vaccine and without treatment. And we should continue to maintain that focus on prevention, prevention, prevention.
There is another direction that I would like to, another perspective I would like to share, Dean Khan, if may I?
Yes, please.
The other thing that we can do to get ready for future pandemics, it's also to have diversity or increase our diversity, especially in the healthcare professions. You know, we need more professionals like you, Roger, like the students who are listening this, that they need to come up as physicians, public health officials, nurses, healthcare professionals that can help us to build a U.S. healthcare system more diverse. And if we are more diverse, we have better solutions. And if we have better, if for the next pandemics, it helps us to be ready and bring everybody on board. I guess a message here will be, you know, not to flatten the curve not only means to follow the hygiene or the social distance practices or wearing masks. It also means to bring everybody on board at the early stages. So we need more diversity.
Very well said, Dr. D'Alba.
Okay, we have another question. This is for Dr. Armando de Alba, and this one is in Spanish, so direct for you. It says, ¿cuál es el panorama que ve para la nueva normalidad en México?
El panorama que veo para la nueva normalidad, it's basically, and I'm going to translate it for also being respectful with our speakers. How do I see the new normality, the new normal? What's the view, how the perspective, or how do I see the new normal coming up, that is coming? I'm kind of like thinking in Spanish and trying to put the words in.
Just say it in Spanish.
Yeah, well, thank you. So, definitivamente, yo lo platicaba en preguntas anteriores, hay mucho que tenemos que hacer para precisamente estar listos de reabrir o empezar a adoptar una nueva normalidad. Entre ellos, lo hemos estado platicando, es hacer exámenes diagnósticos. Los exámenes diagnósticos nos van a dar una idea de qué tan grande la dimensión más cercana o cercana a la realidad de lo que está afectando la pandemia en nuestro país. Entonces, debemos estar preparados y es un buen momento para hacer un análisis, una autorreflexión de precisamente llevar a cabo más exámenes diagnósticos a etapas tempranas, como lo decíamos, no nada más en números, sino también en tiempo. Entre más temprano hagamos los exámenes diagnósticos, podemos aislar a los casos que son positivos, y si aislamos los casos que son positivos antes de que empiecen a infectar personas, muchísimo mejor. ¿Por qué? Porque eso nos va a permitir tener apertura en las políticas públicas, en precisamente empezar a identificar medidas que nos puedan regresar a una actividad más activa en público, válgame la redundancia. Entonces, ¿qué tenemos que hacer? Me gustaría que México se consideraran las prácticas que han funcionado en otros países, como el testing, como también el uso de cubrebocas, que ya la evidencia es muy clara, ya no hay preguntas. Una vez más, lo dijo acertadamente el decano Khan, hemos iniciado esta respuesta pensando que es como una influenza. Hay que cambiar el chip. Esto no es responder a la influenza, esto es responder a un coronavirus. Y en previos brotes de coronavirus, de las medidas más eficientes ha sido el uso del cubrebocas. Entonces, ahí es en donde tenemos que empezar a identificar y empezar a reconsiderar medidas como el uso de cubrebocas, definitivamente seguir las prácticas de manos y de distanciamiento social para precisamente llevar una normalidad. Ahora, esperemos que pronto, en algún momento del siguiente año, ya exista una vacuna o una medicina que pudiera ayudarnos, y ese va a ser el verdadero cambio para todo lo que está sucediendo, el game changer, como le decimos, para precisamente empezar a adoptar medidas más relajadas y podamos tener más libertades en nuestra población. Hasta que no lo tengamos, tenemos que adaptarnos a las prácticas de salud pública, en este caso que es la higiene personal, el distanciamiento social, y sí, en esta plática me gustaría enfatizarlo y dejarlo en claro a nuestra audiencia: el uso de cubrebocas, tapabocas o mascarillas es importante y es recomendable. I hope I answered the question and we can go to the next one. I think you are muted, Dayanira or Dr. Escobar.
I think that we don't have more time. Dr. Khan and Dr. De Alba, would you like to provide each one of you a closing statement or a final thought to our audience, please?
Dinkan, you're muted, I believe.
Why don't I go first, and you can go in Spanish if you like, Dr. D'Alba. Yeah, I do have a final message. I have had the pleasure and honor of going to Mexico multiple times during my life. We have students from there, we have faculty from there, we have staff from there, and I can tell you the talent I have seen is immense in that country, okay? So you have the talent in Mexico to get this outbreak under control. So I guess that's the key message I have. And we have a sort of a guidepost or a roadmap on how to do this in the rest of the world, right? Test and trace, and your own responsibilities around wearing a mask, washing your hands, and social distancing. If you combine that together, use your data well, you can go to the road to zero in Mexico. And as I said, that's going to save a lot of lives, and every life counts, right? For us all on this conference call. But it also will rescue your economy. So those are my final words.
Thank you, Dr. Khan. Dr. de Alba?
I will direct my message in Spanish. Bueno, pues en las mismas líneas que el decano Khan nos ha ofrecido, quisiera también decir, he tenido la oportunidad de ver, yo me formé en México y soy orgullosamente Tuxpan, Veracruz, y he estado en varias partes y he servido a lo que es comunidades rurales y urbanas en México. Sé lo que es formarse como médico, como investigador en México, y tenemos nosotros todos los recursos. Ahorita me encuentro dando clases a estudiantes de medicina, de salud pública en los Estados Unidos, y puedo comparar, puedo comparar que México y Estados Unidos no tenemos mucha diferencia en cuanto a adquirir conocimientos. Adquirimos muy similares, los conocimientos muy similares en ambos países. De hecho, seguimos la literatura muy de cerca y de hecho la intercambiamos, y en Estados Unidos seguimos literatura de México. El talento está. Nosotros podemos también crear nuestra propia datos de investigación. Nosotros tenemos los recursos para poder salir adelante, y estoy seguro que si nosotros utilizamos todos esos recursos y adoptamos y analizamos las prácticas que se están teniendo en otros países, también vamos a seguir adelante. Pero mi mensaje va a ir dirigido sobre todo a las nuevas generaciones, para cerrar, es no permitan que sus sueños se truquen por decisiones de otras personas. No permitan que otros les digan que no se puede. No importa cuál sea su sueño. Trabajen duro. A través del trabajo y de la educación, cualquier sueño se puede alcanzar. Y estoy seguro que ustedes van a alcanzar los sueños que ustedes se propongan. Solamente se necesita dedicación, persistencia y mucho corazón a lo que se haga. Adelante, México, sí se puede.
Gracias, Armando. Again, thank you very much, Dr. Khan, Dean Khan, Dr. Armando de Alba. What a great conversation. It has been a pleasure to be speaking here with you today. Now, I will turn to Maestro Omar Torres for a final message to our audience. Maestro Torres, please.
Thank you very much, Dr. Khan. What a pleasure, Dr. de Alba. Thank you very much for your participation. Without any doubt, this webinar has been one of a kind. And we value the participation of Dr. Ali Khan and Dr. Armando de Alba, and of course, the outstanding trajectory of Dr. Alejandro Escobar. Thank you very much. This is evidence of the genuine academic collaboration between Universidad, Anahuac, Xalapa, and UNMC. As a conclusion of this successful webinar, and on behalf of Universidad Anahuac, Xalapa, our Chancellor, I would like to highlight the support of some dignitaries at UNMC and UN Upfront. Of course, our panelists, but also Dr. Jane Mesa, Associate Vice Chancellor for Global Engagement, Dr. Paul Easterbrooks, Chair Professor, College of Public Health, Dr. Bruce Grogan, Director of Global Engagement. Thank you very much for all your support. And I would like also to acknowledge our Consul of Mexico in Omaha, Maria Guadalupe Sanchez Salazar. Consul, thank you very much for your warmth every time that we visit. And all our allies, Tech Adidam, and all the number of people that have supported the consolidation of this very successful relationship between Anahuac University and Universidad and the University of Nebraska in Omaha. At both fronts, we all have been working really hard to consolidate our partnership with solid initiatives like this one. And thank you all for the warmth, as I said, for every time we visit. And right now, I wouldn't like to finish and end this seminar without introducing Dr. Jane Mesa, who will give the closing message for this webinar on behalf of both UNMC and, of course, her home, Anahuac University. Please, Dr. Jane Mesa, I'm honored to give you the microphone right now.
Thank you so much. This has just been such an inspiring conversation, and I think it really highlights the collaboration between our two universities. This is our second webinar that we've had in about a month, right? So just really emphasizes how we are really committed to this relationship, and it wouldn't happen without you, Dr. Dean Omar Torres Fernandez. So I really, really appreciate everything that you do. I know how much work you did for this, and I really, really appreciate it. And Dr. Escobar for your monitoring and moderating this conversation. I really appreciate it. We talked about some really important things. We talked about testing and tracing. We talked about, I love the analogy of the forest fire and COVID-19. I think that's a great analogy. We talked about health disparities, and we talked about prevention, and we talked about potential treatments. And most of all, we talked about how we could work together, that this is a global problem. It's not just a local problem. And I'm really proud that we can work together to try to solve this problem in our communities. I also want to thank a couple of other people that were involved in this. Dr. Francisco Martinez Marquez, President of the Board of Consultants for the Medical School for Universidad Anahuac, Xalapa. Dr. Rafael Cano Ortega, who is the Dean of the Medical School. Dr. Felipe Sanchez Ancira, Antonio Sanchez Sáenz, Dr. Marcelo Rodriguez Andrade from the Covadonga Hospital Group. I also want to thank you for your participation.
Thank you very much, Dr. Jimenez. It's always an honor. I want to also thank our audience for your participation. As Dr. Jimenez mentioned, we are working really hard to multiply these opportunities of conversation. And well, thank you very much to you all. Again, Dr. Can, Dr. Armando de Alba, it has been an honor. And thank you very much. Please have a nice afternoon. Thank you very much.